Okay, so we'll be having a 2 hour stream. Is this seem better? Lastly, guys. Okay, so coming back, let's start with the stream. So today again I'll continue stomach. So I had left off an acute complication of peptic ulcer, and in another stream I did a little bit of complications, but I wasn't able to do it because I was in class. I didn't complete it fully, so we'll try our best to finish all these topics all the way from complications to surgery for morbid obesity. If it, no, it's not there, but no, actually, someone had taught surgery for morbid obesity actually, so I think it will be there. And after that, I'm kind of skipping liver because liver is somewhat I have done it, but gallbladder I'll do, pancreas I'm going to skip, and spleen I'll do, peritoneum, small intestine, large intestine, intestinal obstruction, rectum and anal canal, and lower intestinal bleeding, all of the good stuff. Yeah. So let's get started. What is this? 490. Yeah. I'll stop somewhere here. So acute complications and chronic complications and hemorrhage also. I have done this, but I'll go very fast. I'll go really very fast. Okay, so acute complications of peptic ulcers. First we have antiduodenal ulcer, perforation, and duodenal ulcer leads. Then you have really. Imagine my surprise, my absolute surprise. The color changed. Okay, so usually patient is long history of peptic ulcer, suddenly complain of feeling something that has given way in their stomach. It may be precipitated by silent excessive smoking, all drugs, etc. Rarely a silent ulcer can also perforate, especially those treated with cortisone. Then it is more common in males. Ratio is 8 to 10 to 1. Right. Then you have two factors which are associated with perforated peptic ulcer: chronic use of NSAIDs and H. pylori. Patients with H. pylori infection and perforated peptic ulcer tend to be younger with male predispositions. So both of these, same thing which you have been taught previously in this length. And prolonged period of dyspnea or NSAIDs category of patients are elderly with equal proportions of both sexes being affected. Perforated ulcer have a mortality of 5 to 10%. Gastric ulcers in the elderly have 10 to 20 to 30%, and golden time to operate is within 6 hours. Stages of duodenal ulcer: you have stages of stages of chemical peritonitis. Immediately after perforation, gastric and duodenal contents leak into the peritoneal cavity. Agonizing pain in the right hypochondrium. Maybe HCl produces the pain. That's it. I mean, it's kind of implied. Episode of copy brown, then marino. And pulse rate increases, patient is very anxious. BP is normal in the initial few hours, problem there is guarding integrity. Then usually on percussion liver dullness is obliterated because of connection of free air and at the right tone of diaphragm. Seen for 2 to 4 hours. And bowel sounds are usually absent. Then stages of reaction, you have peritoneum reacts to the chemical irritants by secreting peritoneal fluid. As a result of this, HCl and bile are diluted by the peritoneal secretion of the peritoneum due to the insult and resulting in improvement of symptoms. Hence, this is called stage of delusion or stage of illusion. This lasts for 3 to 6 hours. Or the signs are worse. And if health is fever more than 120 per minute, hypotension persists, evidence of dehydration due to loss of fluid in the peritoneal cavity. Ascites shifting dullness is present, which is 1200 ml, as you have learned from clinical medicine. Abdominal distension due to fluid and paralytic ileus. Bowel sounds absent. Previously also it was said, and guarding integrity also. All of these are important things. In fact, you know something. Why did I do it like this? In the stage of bacterial peritonitis, the peritonitis gets contaminated with gram-negative organisms, and these gram-negative organisms are from the intestine itself and not from the peritoneum. Then, resulting in bacterial peritonitis, the organisms are from intestine itself and not from the peritoneum. Patient becomes severely ill and dehydrated and toxic with drawn-in cheeks. Then the tongue is dry and coated with bright eyes, hypocritic faces. Hypocritic faces in peritonitis. The cheeks are drawn in, the tongue will be dry and coated with bright eyes, hypocritic faces. Then features of hypocritic hypovolemic and septicemic shock, such as feeble thready pulse, cold peripheries, and high grade fever and persistent hypertension are present. This is stage of bacterial peritonitis. Cross abdominal distension, guarding rigidity, as seen in all stages of generalized peritonitis. All of them suggest okay. Investigation of perforated duodenal ulcer. Complete CBC and reproductive study. And then you have chest X-ray, plain X-ray, or abdomen in that position. Then when in doubt, request a CT. CT scan with contrast. X-ray abdomen is showing erect showing collection of free gas under the right dome of the diaphragm. Then you have plain X-ray showing the lateral decubitus, showing collection of free gas under the abdominal wall. Right here and right here. So treatment, you have A, B, C, D, E, F. So aspiration of stomach contents with the right tube. Blood grouping and cross matching. So temperature, BP, everything you have to do. And catheter also you have to put. Drugs you give injection ampicillin 500 mg IV start 6 hourly. And against gram-positive organisms. Gentamicin 6 mg, 60 to 80 mg for gram-negative. Metronidazole for anaerobic, and the cephalosporins can also be used depending on severity of the shock. Exploratory laparotomy is done through amyl perforation and is identified and closely interrupted We have several sutures which are strengthened by the placement of momentum. Peritoneal wash is given to avoid residual abscess. Abdominal wash with the drain which is removed after 3 to 5 days. However, if it is a large gastric ulcer, it is better to do gastrectomy if the condition of the patient permits. Then, let's see, F is vagotomy and GJ is not done. This is bacterial peritonitis. Vagotinal ulcer. GJ is not done. Post-op, the patient is put on antiviral Cerex. Endoscopy is done after 2 months. If the ulcer persists, it is likely to be a chronic ulcer and an elective operation such as vagotomy and GJ. Simple suture cures all the majority of the ulcers. Fluids are given postoperatively to treat dehydration and postoperatively for 3 to 4 days till the paralytic IVS settles down. Soft abdomen and bowels also present. So early cases of perforation, it can be managed by laparoscopic closure of perforation with peritoneal drain. In fact, a thorough wash is rarely possible with laparoscopy. Subacute perforation is with abscess. Patients present will be having features of sealed perforation. Hemorrhage from pulmonary ulcer. You have chronic, which can cause anemia, or acute, resulting in massive metastasis and bleeding. We have posterior duodenal ulcer, which is commonly bleeding because it erodes into the GJ artery, gastroduodenal artery, which runs posterior to the duodenum. Precipitating factors for hemorrhage have chronicity, sudden severe alcohol, drugs and all, and atherosclerosis of sclerotic artery does not contract, resulting in massive hemorrhage. Then developments of individual is at an increased risk of developing GI bleeding. So increased age, male sex, cardiovascular disease, diabetes mellitus, renal diseases, increased number of medication and anticoagulant use. All of these people will be having increased risk of developing GI bleeding. Clinical features of bleeding peptic ulcer: you have abdominal pain of peptic ulcer disease, hematemesis of melena, features of hemorrhagic shock, all of these, oliguria, brain stain, hypoxia. It's affecting the respiration, which there may not be any abdominal signs, or due to accumulation of blood in the intestine and the stomach, mild distension may be present. Perforation produces abdominal sign and hemorrhage produces systemic signs. This is hemorrhage. Before was perforation. Bleed risk classification. You have blood elevated, pressure is low. Blood pressure is low, elevated prothrombin time, altered mental status, and dysfunction myocardial, renal, and comorbid diseases. We also have forest classification of endoscopic appearance of vehicles. I don't think this is important because it's really hard to remember this. Management, upper emergency esophageal gastroduodenostomy is done to confirm the diagnosis. If the source cannot be detected due to large clots of massive bleeding, it can be repeated through the hours after a stomach wash. And blood transfusion. So emergency upper OGD should be done in 12 to 24 hours of bleeding, depending upon the condition of the patient. Resuscitation is more important than urgent endoscopy. Then elderly patient cannot tolerate shock well. Decision must be taken early. Then conservative line of treatment, you have emergency replacement of blood, raised tube, fast and cold saline stomach wash is given to produce vasoconstriction. Cold antacids are given every 2 hourly, 10 to 20 ml. Every 50 mg, 8 hourly, or IV pantoprazole 40 mg. Majority of cases to respond to conservative line of management within 48 hours. Non-surgical treatment, you have laser coagulation, bleeding without direct contact tissue, NDYAG lesion. Sclerotherapy, you have epinephrine 1 in 10,000, bleeding by vasoconstriction. Bipolar electron before that, where is 3? 2% ethanol, main fluorescent. Then success rate is 90% cheap and easy treatment. Then there is a hemoclip application. Bipolar electrocoagulation, failure rate is half of that. Surgical control of bleeding peptic ulcer, you have indications, barriers of endoscopic hematosis, rebleeding, bleeding requiring transfusion of more than 2 liters. Adult patient with rebleeding, massive hemorrhage leading to shock, recurrent hemorrhage. Endoscopic prognostic factor, you have it is a residual level in 40 to 60% rebleeding ulcer is more than 2. Urinary clot 20% rebleeding, flat pigmented spot 10% rebleeding, then clean ulcer base, really it is bleeding. Then you have role of surgery, which is to explore when the endoscopy fails, explore when deblooding occurs, explore an unstable patient, gastrojejunostomy, underlining of ulcer base for CDU and partial gastrotomy for the gastric ulcer. So you can also do endotherapy. Bipolar failure rate is 80%, sclerosis failure rate is 20%, and hemoclip application can be tried. No failure rate was being given. So surgery for bleeding ulcer, you have laparotomy and anterior gastroduodenostomy. Visualize the bleeding under the first part of the duodenum, underrunning of the ulcer base by tight suture, or 4-quarter ligation of duodenal artery, using non-observable sutures. Gastroduodenotomy incision is converted to a pyeloplasty, followed by vagotomy. So surgery for benign, this was duodenal ulcer now. Okay, surgery for benign gastric ulcer, you have laparotomy, gastrotomy, and visualize the bleeding ulcer. Laparotomy, gastrotomy, visualize underrunning of the ulcer base. Partial gastrotomy is the best method. Treatment provided general condition of the patient is good. Otherwise, local excision of ulcer, followed by GJ or pyeloplasty can be done. Hemostatic methods currently employed include thermotherapy, heat probe, multipolar or bipolar electrocoagulation, injection of ethanol or epinephrine solution. Bleeding is controlled. Long-term medicotherapy, including antisecretory agents, usually in the form of proton pump inhibitor, in addition to testing for H. pylori. If H. pylori is present, documentation of eradication should be performed after therapy. So differential diagnosis of hepat hematemesis. If upper GI bleeding, 80% from the upper GI, 20% is from below GI, which is a colon, 1% from small intestines. Bleeding proximal to the ligament of treats. Hematochezia. Hematemesis. Hematemesis refers to vomiting of fresh red blood. Melanemesis is referred to vomiting of dark altered blood, or both are included in the upper GI tract bleeding. Small bowel, even though it is a mid-gut structure, some of its lesion can produce hematemesis. Hence, they are also included under this setting. I mean, none of these are important. I think esophageal causes you have malariation. Malariation also. Just a second, I forgot. Malariation syndrome is bursting of the esophagus will burst whenever there is of these things, no? If there's increased pressure. It's okay. Visualizes cancer. I don't feel this is important topic, so I'm just going to skip. But yeah, gastric polyp, the defolate vascular malformation, which we'll do next, and duodenal causes also arteriovenous formation, carcinoma, fistula, divertula, papilla, papillae, polyps, purpura, hematobilia, soda aneurysm. So initial investigation, endoscopy can be done. Isotope study, CT angiogram is the gold standard. Treatment is treating the shock. NG tube aspiration, you have non-virus means it is possible upper gastrointestinal source. Bloody fluid is UGI source, and bilous non-bilous fluid is probably lower gastrointestinal source. Non-bilous, non-bloody, bloody, and bilous, non-bloody. Upper GI endoscope causes blood animal. Appropriate treatment and surgery can be performed. Selective visceral angiography also can be done if the cause is not identified, and if there is massive hemorrhage and no source identified, then you can do selective visceral angiography, and RBC scan, repeat UGI, endoscopy, CT angiogram can be done if no source is identified. This is a CT hepatic angiogram demonstrating extravasation of a dye into pseudoaneurysm of a branch of middle hepatic artery and thrombus, which is a case of hematobilia. Massive hematemesis in the patient of hematobilia. Okay. So assessment of all this, you have initial assessment, abuse of drug, alcohol, previous abdomen pain, history of jaundice, liver sulfuric anemia, and general physical examination. You can do tubercular atrophy, cirrhosis of liver, palpable supraclavicular node is carcinoma of the stomach, arthritis, you have multiple joints involvement, you have acute erosive gastroenteritis, use of NSAIDs. Purpuric spot, you have bleeding tendencies. Abdominal examination, you have palpable spleen, ascites, palpable due to portal hypertension, and then palpable stomach mass is due to carcinoma of the stomach, and tenderness in the epigastrium is peptic ulcer disease. Assessment of hemorrhage, you have massive, moderate, and mild. Massive portal hypertension, acute erosive ascites, chronic peptic ulcer. Moderate is chronic peptic ulcer, and mild is other causes. Diagnostic anxiety detected as a total gastrectomy. This is when showing bleeding in gastric ulcer. Apogee bleeding due to testosterone grade 3 is a facial varices bleeding. Due follow vascular malformation, then joint ulcer, gastric ulcer with bleeding. Indications of surgery: elderly patient with rebleeding, gravity of blood groups, splitting muscles in endoscopy. So, splitting muscles is something higher up. Okay. Surgery, surgical management of individual case has been discussed along with consent chapter. However, summary has been provided here. Okay, this is this is always a complicated thing. Surgery, surgical management of individual cases. Yeah, okay. Apogea bleeding can occur due to various causes, or acute gastritis, chronic peptic ulcer, and esophageal varices are the three important causes of bleeding. Endoscopy is the investigation and for the diagnosis of apogea bleeding. Today, most of the apogea bleeding is managed either in the form of injection sclerotherapy, laser coagulation, or with powerful H2 blockers or PPI. In appropriate cases, surgery is definitely indicated. Some common conditions which give rise to hematemesis are discussed in the following pages. So, conservative failure in surgical method, acute erosive gastritis, conservative, all of these conservative except duodenal polyp is endoscopic smearing, and carcinoma of the stomach is direct gastrectomy. So, if acute erosive gastritis is you do rarely gastrectomy, chronic duodenal ulcer you do vagotomy and underrunning and pyloroplasty, chronic melanoma syndrome you do suturing of the tear, hematobilia you do therapeutic embolization. If that fails, then you do ligation of the feeding vessel. Varicose bleeding you do if conservative treatment is sclerotherapy. If it fails, then you do devascularization. Hemosuccus pancreatitis. If conservative is therapeutic embolization. If it fails, it is ligation of pseudoaneurysm. Therefore, you do injection sclerotherapy, and if it fails, you do wide excision. This is an endoscopy showing emergence. We have acute peptic ulcer, also called acute erosive gastritis or acute stress ulcers or acute steroidal ulcers. Acute gastric mucosal lesions. AGML. Etiology is drugs, aspirin and analgin, steroids, phenylbutazone. Any stress or acute infection, also which results in sepsis. It can be following tetanus, and afterwards they are called Curling's ulcer. After the head injury or neurosurgical operation, they are called Cushing's syndrome ulcer. Following hypotension and shock, there is hypoperfusion, which results in mucosal and acute stress ulcer. Example: myocardial infarction, trauma, sepsis. Excessive consumption of spirits and smoking, respiratory failure can also produce acute lesions. AGML. Culling ulcer after head injury or neurosurgical operation, Cushing's ulcer. stress is acute infection. Drugs, aspirin, hypotension and shock. There is hypoperfusion and mucosal ischemia and acute results. For example, myocardial infarction, trauma, and sepsis. Excessive spirit and smoking and respiratory failure can also produce acute erosions. Diffuse mucosal damage and disruption of gastric mucosal barrier. Reflux of bile may also play a precipitating factor. This results in acute erosions when they are 1 to 2 mm and acute ulcers when they are 1 to 2 cm in size, shallow and well demarcated. Entire stomach is involved by these ulcers. Dyspepsia, hematemesis, acute abdominal pain due to acute erosion, subperforation, flaccid. Drop in PP. In ICU, drop in PP. Admission in ICU. Rice tube to be introduced. Regular antacids. Replacement of blood. Specifically the coagulation factor, injection antidine, opataprazole. Immunotherapy if there is solitary bleeding site, surgery with modern investigation and their therapeutic role in addition to good ICU care or relieved operating cases. Match without surgery in spite of about treatment. If the condition deteriorates and for total GJ, no, gastrectomy or subtotal gastrectomy may be necessary. As a life-saving method. Bleeding is chill. Diagnosis is endoscopy to confirm diagnosis and rule out other causes. Mallory syndrome occurs due to tear in GJ mucosa near the esophageal-gastric junction. It's called partial thickness mucosal rupture, and in Borheim syndrome, all layers are inordinate. Clinical feature: patient is usually middle-aged who, after consumption of alcohol, vomits as the food contents. First, during the course of vomiting, the process of straining and relishing at 30 years. Reaching a tear develops near the esophageal-cardiac junction, hence the second volume contains the blood. Sometimes the bleeding can be so massive they produce hypotension and shock. 90% of the cases, the bleeding stops spontaneously. Conditions vary in the malaria hysteresis in spirit of alcohol, pancreatitis, infection myocardial, renal failure, infection pseudocholecystitis, and tumor pregnancy. Spirit. Within the endoscopy, bleeding will be stopped. The malaria hysteresis. Full thickness is Borheim syndrome. Partial thickness mucosal rupture. I'll do for another 10 minutes and I'll take a little bit of a break. So, chronic complication of peptic ulcer, you have gastric outlet obstruction. Earlier, it is called pyloric stenosis. Just a second. Treatment: urgent resuscitation of hemorrhagic shock, then endoscopy, confirm diagnosis, registry of aspiration for 48 to 72 hours, endotherapy. Injection 1 in 1000 elevation is effective. If not, high hemoglobin chemistry. Multipolar electronical coagulation. When all others fail, high gastrotomy and underrunning is necessary with 206 surgeries. DFA vascular formation is an unusually large artery running in the submucosa which lies close to contact with mucosal membrane. Submucosal erosion precipitates the bleeding. 80% of the cases bleeding occurs within 60 centimeters or more. Esophageal junction, gastric junction at lesser curvature. Endoscopy therapy must be tried and if necessary repeat. Massive painless recurrent hematosis with hypertension is presenting feature. Angiography to confirm the bleeding lesion, angel form and visualization. Failure to achieve control of the bleeding, gastrotomy and wide excision. Gastric antral vascular ectasia, GAVE, uncommon cause of chronic GI bleeding resulting in iron deficiency and water gland stomach because of the presence of long streaky area which are present in the stomach resembling a water gland. So our health also will get this. Subacute complication of peptic ulcer. Oh yeah, this one. Okay. And upon proliferation of the peptic ulcer, which is in a way momentum, may result in residual abscess in one of the subphrenic spaces. Response to conservative treatment. Otherwise, percutaneous drainage can be done with ultrasonographic guidance. Women in 50s. So watermelon stomach, watermelon. Women in 50s. Antrum commonly involved. TIPSS for patient with portal hypertension. Ectasia of antral vessels. Red parallel strips on mucosal folds are characteristic. Microsulfidomuscular hypoplasia. Arenization. Endoscopy is a treatment of investigation of choice. Liver disease in 25% of the patient, and other diseases you have autoimmune connective tissue like which may be associated, including Helicobacter pylori, and no control of bleeding. Antrectomy may be required. Antrectomy. So I'll finish chronic complications. Yeah. So chronic complication, you have gastric outlet obstruction. It was called pyloric stenosis. Our gastric outlet obstruction is better. And then chronic cicatrization of duodenal ulcer or juxtapyloric ulcer results in narrowing of the pyloric antrum, which is described as pyloric stenosis in India. Pyloric stenosis is more common in South Indian patients who usually present with long history of duodenal ulcer and recent history of vomiting. Pyloric stenosis in chronic duodenal ulcer is a misnomer. Stenosis is very often formed in the first part of this duodenum. In case of pyruvate cancer, two pyruvate stenosis occur. Metabolic changes such as paradoxical aciduria are usually seen in patients with ulcer, not carcinoma. Relative achlorhydria in the latter. Paradoxical aciduria. Hunger pain of duodenum disappears, replaced by dull aching pain because of gastric distension, colicky pain due to hyperperistalsis of stomach. Vomiting is profuse, projectile, persistent, foul smelling, and non-moist. May be distension of upper abdomen. And there is visible gastric peristalsis, VGP. Stomach that is C. Signs visible gastric pulsation. Starts in left hypochondrium, runs across cervicals and ends in the right hypochondrium. VGP is diagnostic of pyruvate stenosis, right to left peristalsis, seen obstruction, continuous. If it is not seen, it can remain prominent by asking patient to drink at least 5,000 to stimulating the abdominal flicking motion. Again, this doesn't make sense because we have no idea what the flicking motion is. How do you stimulate it? Hit like this or what? Okay, then subcutaneous splash. It should be done on a fasting stomach. This should be done before asking the patient to drink water. There's always in pyloric stories, there's always a sheet of fluid in the stomach which gives a splashing sound that can be heard with or without these contractions can be felt. Thus, stomach which is seen, felt and heard is diagnostic of pyloric stenosis. Then you have auscultative percussion test or auscultative scraping test to find the gluteal curvature of the stomach. Keep the bell of the stethoscope in the center of the epigastrium. Ask the patient to hold the bell of the stet and press radially. Pressure over the stomach gives a dull note because of presence of fluid. When the note changes, it indicates a greater curvature of stomach. Mark on it abdomen. Instead of percussion, scraping can be done with fingernail. Join the line joining 3 or 4 such marks outlines the greater curvature of the stomach. Chronic complications. Still have to finish it. That's again. Okay. The center of the application was the patient with the percussive because of presence the note changes. That's it. That's only line. Saline load test. 700 ml of normal saline is infused into the stomach over a period of 3.5 minutes through a NG tube and clamped. If the volume more than 350 ml can be aspirated, it indicates obstruction. Electrolyte changes. You have hypokalemic aciduria, alkalosis, hyponatremia, hypokalemia, paradoxical aciduria. Gastric gut obstruction, you have vomiting, you have hypochloremic gas alkalosis, excretion of HCl with sodium, hyponatremia and dehydration, sodium retention, potassium and hydrogen excretion, hypokalemia, and paradoxical aciduria. It's very complicated. Investigations very mean X-ray. I usually dilated eye and low stomach. Barium does not enter the luminum, and barium mixed with food residue can give more mosaic appearance and delaying evacuation on repeat X-ray of barium into the duodenum. The gastroscopy scope will not enter duodenum, stomach is full of foul-smelling food residue. Gastroscopy is also done to rule out carcinoma of the stomach. Electrolyte study. So, treatment you do aspiration with the residue. Oh my god, why is it changing? What did I do? Decreases the edema of the stomach wall. Blood is arranged for surgery, blood may be charts you do. Drugs, antibiotics for surgery. Exploratory laparotomy, medical foods, GG. Pyeloplasty should not be done, should be because of duodenum is scarred, cicatrized, fibrous and narrow. Fluids to correct electrolyte abnormalities. Hyponatremic, hypoloremic, hypolimic, kalemic acidosis, ringer lactasis is ideal supplement. Post-operatively, these patients recover very fast. Dehydration improves and nutritionally they show dramatic improvement. Even the gastric tone may return after a few years. Then you have teapot deformity, handbag stomach, causes shortening of the nasal curvature due to fibrosis. Such stomach resembles a teapot. As a result of this, the pulse becomes non-dependent, stasis occurs. Treatment, you have partial gastrectomy followed by Billroth J or Billroth I anastomosis. You have hourglass contracture, which is a single shaped ulcer under the ulcer. The lesser curvature gets cicatrized, involving both surfaces of the stomach, resulting in conversion of stomach into two compartments. Features of stasis such as fullness, distension, and peristalsis, and vomiting are present. Females affected more often, weight loss, center decreased, Billroth partial Whereas one partial gastrectomy will remove the second spot approach. Perforation into pancreas, posterior gastric ulcer can perforate into pancreas. Pain relieved on and that's all for this topic. I will take a break for at least 15 minutes, maybe 17 minutes, and I'll come back. So yeah, I'll be right back. Getting back. Let's see. I'll finish carcinoma of the stomach. Yeah, I'll finish carcinoma of the stomach. Okay, I'll finish half of carcinoma of the stomach. Okay, yeah. Half of carcinoma of the stomach. This now I'm finishing it, I think. Maybe even a quarter. Disorders, idiopathic hypertrophic polarization associates. Okay, fine. See, stomach. Let's get started. Carcinoma of the stomach is more common 2 times in men compared to women, and it is rare below 20, and average age is 65 years. Diagnosis, okay, fine. The differential diagnosis is cicatrized chronic ulcer and carcinoma of the pulmonary cancer. Age is older, duration is longer, pain is usually absent, but vomiting is there, history of vomiting is there, appetite is increased because of vomiting, severe loss of appetite in carcinoma of the pulmonary cancer, and weight loss will be present. It will be significant in pulmonary cancer. Anemia is not a feature, it will be present in pulmonary cancer, and the mass is non-palpable in cicatrized, but it is a hard irregular mass which is palpable in carcinoma of the pulmonary cancer. Mass is the diagnostic factor. I think duration of symptom. Appetite is decreased, weight loss is present. Yeah, okay. Carcinoma of the proximal stomach, which is the cardia. It is incidence is increasing, obesity and high socioeconomic status group. It is more aggressive, thin muscularis mucosa, hence submucosal invasion is seen early. Diagnosis may be delayed as endoscopic needs technical expertise, and signature carcinoma is common. Surgical resection involves esophageal anastomosis, which is technically demanding. Leak rates are high. Prognosis as well. More aggressive. Thin muscular hence submucosal invasion is seen early. So, carcinoma of the stomach is commonly associated with H. pylori as proximal stomachs are more advanced at the time of presentation. 3 year survival is 10 to 20%. Those who undergo potential curative resection have 5 year survival of 25 to 50%. A subnet of 3-month duration endoscopy revealed growth in the body of the stomach. Exploration lasts for aortic nodules. Present total gastrectomy was done. He died after 6 months into extensive metastasis. No wonder carcinoma of the stomach is called captain of men of death. And risk factors for carcinoma of the stomach: gastric ulcers, pernicious anemia, polyp, gastritis. Environmental and dietary factors. Persons who consume red meat, cabbage, spices, spirit, salted fish. Smoked salmon fish was responsible for increased incidence of stomach cancer in Japanese population, probably related to the release of polycyclic polyadenones and aromatic amino acids. Smoking spicy food and alcohol consumption over a period of many years produce chronic gastritis, which may change into carcinoma of the stomach. You know this. Okay, fine. This much is enough. WHO recommends increased consumption of fruits and vegetables. Vitamin C, an antioxidant, is a productive agent as ascorbic acid prevents nitrates to nitrites. Pre-cancer conditions in atopic gastritis, which may be due to smoking, spicy food, continuous ingestion of drugs, influenza by intestinal, etc. May have pernicious anemia, increased risk 4 to 5 6 times older than carcinoma when compared to general population. Atopic gastritis precipitates illness of polypid and multicentric 54 increase. Intestinal and liver cancer. Both type A and type B gastritis can produce carcinoma of the stomach. Type A is proximal stomach, type B is distal stomach, adenomatous polyp which can occur after which occurs in the antrum, highest risk of malignant transformation. Other polyps more than 2 cm, 10 to 12% of malignant transformation. Polyp more than 2 cm pedunculated polyp can be removed endoscopically. High chances of malignancy in cystic polyps. Mendel's disease is a protein-losing enteropathy along with giant hypertrophy occurring because of fold. Weak and size condition. Mendel's disease. Chronic gas biliary infection, you have high acid secretor, which is central gastritis. Body gastritis, which have high acid, which increases body gastritis and leads to duodenal ulcer. Low acid secretor, you have antral gastritis and body gastritis. Antral gastritis, gastrin impaired function of the body is seen, and it decreases the acid leading to cancer. Patient with pernicious anemia or 6 to 8 times developing gastric cancer. Pernicious anemia is an autoimmune gastritis infection in mucosal and necrosis. There is gastric cancer. Autoimmune gastritis of the exotic mucosa increases risk of stomach, you have diet low in vitamins C, E, high salt diet, smoked food, and gene mutation. You also have chronic H. pylori infection in the stomach. Intestinal subtype of chronic superficial gastritis, atrophic gastritis, which is still reversible. Intestinal metaplasia, dysplasia, unreversible, you have carcinoma of the stomach. Interleukin-1 gene cluster polymorphosis can enhance the production of interleukin-1 alpha, associated with the increased risk of hyperphoria induced by H. pylori, thus gastric cancer. Familial clustering of H. pylori infection associated with inherited polymorphisms linked with hypochondria may explain the increase in cancer risk in individuals in a family history of gastric cancer. Benign gastric ulcer is 2 to 5%. Carcinoma arising in gastric ulcer is called ulcer carcinoma of stomach. PGJ or gastric resection. For a period of 10 to 20 years, such a carcinoma is called as stem carcinoma. So, duodenal gastric bile reflux. Stem carcinoma. Then you have genetic and family factors. Carcinoma of the stomach can run in families. One second. Sorry about that. So, genetic and familial factors. Carcinoma of the stomach can run in the families. However, only 10% of the family patients can give a family history of carcinoma of stomach. Carcinoma of stomach is more common in patients with blood group A. These have different mucopolysaccharide secretion in the stomach and greater susceptibility to ingested carcinogens. They develop diffuse carcinoma. Then several genetic alteration such as activation of oncogenes, deactivate suppressor genes, inactivation of suppressor genes, reduction in cell additions, met procogens. Gross types, you have cauliflower growth with friable tissue, which leads to minor bleeding causing anemia. Yeah, infiltrative type of lesion, diffuse subdermal mucous which converts the stomach into small contracted functional stomach, intestinal or leather bottle stomach. Insultivity with classical aortic edge, central slug. Also cancer, carcinoma in pre-existing gastric ulcer. Complete destruction of muscle cord is seen. Colloid carcinoma is many cells are buried by colloid material. Krukenberg's tumor. Familial gastric cancer 10%. Hereditary diffuse gastric cancer HDCGC carcinoma is like before between below 40 years. Nutrition increases 60 to 50%. Prophylactic gastrectomy is recommended. Diffuse carcinoma FGC at least 3 radius into brains and affected one of them before 20 years of age. Hereditary non-polyposis colon cancer increased 10% risk of gastric cancer. Pathology: 95% of all malignant neoplasms are adenocarcinomas. And separates gastric adenocarcinoma into intestinal or diffuse type based on histology. Other histological types include squamous cell carcinoma, adenocarcinoma, carcinoma tumors, stage 2. Early gastric cancer is adenocarcinoma limited to mucosa and submucosa of the stomach. I think I'll study for another 15 minutes. Okay. I'll see. I think I can do till clinical features. Okay. Early gastric cancer is defined as adenocarcinoma limited to the mucosa of the stomach, submucosa of the stomach, regardless of the lymph node status. It is common in Japan, where gastric cancer is the number one cause of cancer death. Approximately 10% with the early gastric cancer will have lymph node metastasis. Japanese classification: you have type 1, type 2, type 2A, B, and C. Type 3 extravasated division without any that may extend into muscular dystrophy. Japanese classification. Type 1, type 2. Type 3. Lesion centering. This Lauren classification is more important. Intestinal environmental gastric atrophy, men more than women, higher incidence with age, gland formation is present, hematogenous spread, and microsatellite instability, APC gene. P56, P16 activation. Familial blood group A does not arise in gastritis of men more than men. Young age group, poorly differentiated, trans lymphatic or lymphatic spread, decrease E cadherin, P56 and all inactivation. Whereas here it is microsatellite instability, hematogenous spread and lymphatic spread. Early gastric cancer is defined as adenocarcinoma limited to the mucosa and submucosa of the stomach regardless of the lymph node status. Mm. 10% of the patient with early gastric cancer will have lymph node metastasis. 70% will be well differentiated, 30% will be poorly differentiated. Overall cure rate is dedicated resection and lymphodectomy is 95%. In some Japanese cultures, 50% of the gastric cancer treated are early gastric cancers. In US, less than 20% are early gastric cancer. Yeah, I don't think so. It's important. Criticism for early gastric cancer, you have 5-year survival is no negative. Early gastric cancer is more than 95%, or it falls to 70% if not so positive. Suggestion of positive not cases should not be included in the early gastric cancer. Advanced gastric cancer refers to involvement of muscularis mucosa or serosa with or without involvement of lymph node. Goldman classification system. So the Borman, this system divides gastric carcinoma into 5 types depending on the lesion's macroscopic appearance. Type 1, which presents a polypoid fungating lesion. Type 2 is ulcerative lesion surrounded by elevated borders. Type 3 is ulcerating lesion with infiltration into gastric wall. Type 4 is diffusely infiltrating lesion, and type 5 is lesions that do not fit anyone. Depress type, protruber type. Lacus platica is seen to be described type 4 carcinoma. Titinus platica, entire stomach though. So diffuse form of gastric adenocarcinoma, you have Lenitis plastica. It is poorly differentiated and lacking gland formation, composed of sigmoid cells, sigmoid cells. Poorly differentiated. Consists of tiny clusters of small uniform cells tend to spread submucosally as inflammatory infiltration, metastasis early. Protospread is barely transmission through the lymphatic conversion. Generally does not arise prior to onset of gastritis. More common in women, affects a slightly younger age group, associated with blood A and familial occurrences, suggestive gene etiology. Intraperitoneal metastases are frequent. Prognosis is less favorable for patient with diffuse subtype histology. change it to 4. Plastic. And this is what is classified classification. Lineatus plastica and diffuse carcinoma. Localized lineatus plastica. Yeah, the WHO classification. Clinical features. So I think I studied for 1.5 hours. Yeah, I did say it is 1.5 hour stream. So yeah, okay, I'll catch you guys in the next episode. Thank you for watching, and yeah, here's a lot of loud noises for you. No, I do not want smileys and people. Okay, I'll catch you guys in the next episode. I'll probably complete stomach cancer. I finish stomach tomorrow, and after stomach I'm not doing anything else. I'm doing peritoneum, small intestine, large intestine, all those stuff. Okay, and thank you for watching. See you guys.